Hello everyone. The topic that we are going to discuss today is heart failure. So previously this was called as the congestive heart failure. Now the term congestive has been removed because of the reason that not every case of heart failure have congestive symptoms. Now we'll discuss this topic in this outline, starting with the definition, pathophysiology, classification, causes or etiology, clinical features, diagnosis, and finally the treatment. So starting with the definition, I broke it down into multiple parts just for our ease of understanding. It is a complex clinical syndrome resulting from any structural or functional impairment. Resulting from any structural or functional impairment of ventricular filling or ejection leading to the cardinal symptoms of dyspnea, fatigue and edema. So you will be able to understand this when we come across the pathophysiology and clinical features. Don't worry about it now. So we have different types of failure. Previously, there were diastolic and systolic failure. Now these terms are not being used clinically because in each and every patient there may be a combination of systolic and diastolic failure, but one of them may be predominant. Okay, but for the sake of understanding, it's better to understand what is forward failure or systolic failure, what is backward failure or diastolic failure. Okay, these terms we are learning them as a part of the pathophysiology right now. So look at the first image. The first image is a normal heart. The second image, as you can observe, when you compare it with the normal heart, the chambers are significantly enlarged. The ventricular wall is thinned out. It is an image of dilated cardiomyopathy. And when you observe the third image, as you can see, the size of the heart appears to be more or less normal, but the ventricular thickness is very much high. And because of the ventricular thickness, it is also going to reduce the ventricular volume, as you can see in the image. So in the normal heart, so the ventricles fill with blood in diastole, right? It is well known. And 60% of the end diastolic volume is pumped out. So at the end of diastole, whatever is the blood that is left in the ventricle, out of which 60% is pumped out, that is called as ejection fraction. What fraction of end diastolic volume is pumped out in each stroke, that is ejection fraction. So here we have an ejection fraction of 60% or more. But when you look at the second image, because of the increase in the volume of the ventricles, the heart will be able to accommodate more blood, but because of the ventricular thinning, it won't be able to pump the blood as a normal heart does. Okay, so the ventricles fill with more blood in diastole, and less than 50% of the end diastolic volume is pumped in systole. Less than 50% of the end diastolic volume is pumped in systole. Now, when you look at the third image, the ventricular myocardium is thickened, and the ventricular volume is significantly reduced. Thereby, the ventricles fill with less blood now. The ventricles fill with less blood now, and then even though the ejection fraction is being maintained by equal to or more than 60%, but still, if you talk about in terms of quantity, the quantity of blood leaving the ventricles is very much reduced. Hope you understand this. Now, if you have watched my previous videos, you already is aware of this circuit. Now, what happens in forward failure, what happens in backward failure of the left and right hearts, we'll see in detail. So if you talk about the forward failure of the left heart, suppose the left ventricle is not functioning properly, it is not able to pump the blood forward. What will happen? The cardiac output will be reduced, the blood pressure will be reduced, and the patient will have syncope and fatigue. Right? So what happens when there is pooling of blood because there is obstruction in front, and the left atrium is not able to empty the blood into the left ventricle? It is called as a backward failure, and the patient will have pulmonary edema because lungs is going to bear all the pressure that is loaded in the left atrium, and because of the alveolar filling with the water instead of air, the patient will develop dyspnea, and of course the paroxysmal nocturnal dyspnea and orthopnea are the characteristic features of cardiac dyspnea. Right, now let's move on to the right side. If the patient has forward failure on the right side, what do you think would happen? So if the right side of the heart is not pumping properly, then what will happen? The amount of blood reaching the left side is also significantly reduced, and eventually the cardiac output and blood pressure is also again reduced, because the blood reaching the left heart is significantly reduced because of the forward failure of the right heart. Right. So again, the cardiac output and blood pressure is reduced. Now, when you talk about the backward failure, the right atrium is not accommodating blood. Now the SVC and IVC are getting congested. Now, what do you think will you be able to see? You will see elevated JVP and then pedal edema and congestive hepatomegaly in the abdomen as well on examination. Right. So these are the clinical features of forward and backward failures on right and left sides. Hope you understood the fluid mechanics here. Now we come to the proper classification that we are following. It is based upon the ejection fraction, which we will find out by doing a 2D echocardiography. So ejection fraction is nothing but stroke volume by end diastolic volume. What volume of end diastolic volume is pumped out with each stroke of left ventricular contraction? That is what is ejection fraction. So the heart failure is classified into three types: heart failure with preserved ejection fraction, when the ejection fraction is more than 50%; heart failure with reduced ejection fraction, when it is less than 40%; heart failure with mildly reduced ejection fraction with a range of 40 to 50%. Okay, it was previously called as mid-range ejection fraction. Now it is simply called as the mildly reduced ejection fraction, because the treatment would be the same for the heart failure with reduced ejection fraction as well as the mildly reduced ejection fraction. Okay, and as you can see, if you saw in the previous image as well, when the patient was having a restrictive cardiomyopathy, that there was diastolic dysfunction. So in heart failure with preserved ejection fraction, diastolic dysfunction is more prominent than the systolic dysfunction, whereas in heart failure with reduced ejection fraction, systolic dysfunction is more prominent than the diastolic dysfunction. The same applies for the heart failure with mid-range ejection fraction as well. Now we have a couple of more terms. Heart failure with recovered ejection fraction. This is commonly called for certain causes where the ejection fraction resolve with the treatment. Okay, so these are, you can call it as reversible heart failures. So they are stress cardiomyopathy, fulminant myocarditis, peripartum cardiomyopathy, toxin mediated cardiomyopathy, that is alcohol, chemotherapy and immunotherapy. Even after you stop the intake of drugs, after you stop the intake of immunotherapy as well, the heart failure may recover by as you can see in the improvement in the ejection fraction. Now, high output heart failure. Where do you see high output heart failure? The high output heart failure can be seen in anemia. These are all the hyperdynamic states as such. Thyrotoxicosis, wet beriberi, arteriovenous shunts, may it be iatrogenic or pathological, chronic liver disease, and obesity. All of these causes can result in high output heart failure. Now let's look at the causes of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. But overall, the most common cause in males as well as females is hypertension. After that comes the coronary artery disease. Right? Now let's look at the causes of each of them. That is heart failure with reduced ejection fraction. The causes are coronary artery disease, cardiomyopathy, usually dilated cardiomyopathy, and any valvular heart disease can also result in heart failure eventually, arrhythmias, myocarditis. These are certain causes of heart failure with reduced ejection fraction. But when you talk about the heart failure with preserved ejection fraction, the simple comorbidities like hypertension, diabetes, obesity, coronary artery disease, HOCM or restrictive cardiomyopathy, atrial fibrillation, chronic kidney disease, COPD, and finally the cardiac amyloidosis. So these are some causes to enumerate for the causes of the heart failure with the preserved ejection fraction. Now let's move on to the clinical features. So if you have understood the features of forward failure and backward failure, it is very easy now. So we have either symptoms of backward failure or the symptoms of forward failure. What are the symptoms of backward failure? I'm just listing them, whatever we have discussed previously. If there is pulmonary congestion, the patient will have dyspnea, paroxysmal nocturnal dyspnea, and orthopnea. When the patient has systemic congestion, the patient will have congestive hepatomegaly as well as pedal edema. What are the features of forward failure or the features of low output or low cardiac output? The patient will have obviously reduced blood pressure and cardiac output, but the patient feels fatigue and syncopal attacks. The patient can also have nocturia because of increase in natriuretic peptides in heart failure. And what will you find on examination? These are all the symptoms. And on examination, of course, in the early phase of heart failure, because of compensatory mechanisms like increase in the sympathetic activity as well as RAS activation, the patient will have increased blood pressure and pulse rate. But when the patient has chronic heart failure, when it is gradually decompensated, I mean, even though the compensatory mechanisms are not able to maintain sufficient output, then in severe heart failure, the patient will have reduced blood pressure and pulse rate as well. So the patient, you will be able to appreciate a steady pulse with very low volume pulse, and advanced heart failure will also have the pulses alternance. Okay, pulses alternance. We have discussed about pulses alternance in the pulse chapter. You can go through it. Then on examination of the chest, you will have bilateral rales or bilateral crypts because of pulmonary edema, and V's as well when if the patient has the bronchial congestion. See, pulmonary edema is because the alveoli are filled with fluid, whereas V's can be because of bronchial congestion because of fluid accumulation, and sometimes the pulmonary edema can also irritate the bronchi, thereby causing bronchospasm. That can also result in V's. And JVP, when you observe it, it is elevated and it is pulsatile, whereas in tamponade, it is non-pulsatile. Why is it non-pulsatile in tamponade? We'll discuss it when we talk about the tamponade in pericardial diseases. Now let's look at the labs. If you can see in the image, you can see we have three different kinds of lines which have been shown in the image, A, B, and C. All of these are the Kerley lines only, and all of these lines are because of the engorgement of lymphatics in the interlobular septa. Okay, but the lines have been designated because of its structure. But how are they different? On chest X-ray, the Kerley lines are A, B, and C. And if you look at the A lines, A for, remember, you can remember this by using a simple word letter mnemonic. So A for amply long lines, and they do not branch. They are straight, they are long, and they don't branch. And A also appears little like H, so, and it is originating from the hilum, and they are moving towards, and the lines are moving towards the upper lobes. Then B for brief length, and B for base, or the middle and the lower lobes. The Kerley B lines are located in the middle and lower lobes, and they are located in the base of the lungs. You can remember it as the base, and they are of very brief length. The C are branching ones, which are forming a complex network. C for complex network due to the interlacing fibers and branching. Okay, all of these again are due to the engorgement of the lymphatics in the interlobular septa. Now let's look at the other labs. After you do the chest X-ray, which may show the Kerley lines as well as any chamber enlargement, what will you see? If there is a chamber enlargement, the patient will have increased cardiothoracic ratio. When the maximum diameter of the heart is more than that of 50% of the thoracic diameter, you call it as high cardiothoracic diameter. That indicates cardiomegaly. And of course, Kerley B lines are prominently seen. And cephalization of the pulmonary vessels are seen in pulmonary edema, and chronic heart failure may also result in pleural effusion. Usually, the bilateral pleural effusion is commonly seen in heart failure. And on doing an ECG as well, you can observe the chamber enlargement if there is a previous history of coronary artery disease with pathological Q waves. All you can observe on ECG. And 2D echo will clearly tell you whether the chamber size is enlarged, whether the ejection fraction, right? The entire classification of heart failure is based on the ejection fraction now. The 2D echo is going to give you that information. And serum NT-proBNP. We can do a BNP or serum N-terminal pro-brain natriuretic peptide. This BNP is produced from the ventricles when it is under a lot of pressure. So it has high sensitivity and low specificity for heart failure. Low specificity because it may be elevated in women as well as in elderly age group as well. So we have certain new markers for the diagnosis of heart failure, soluble ST2 and galactin-3. Now let's look at the pathophysiology. We have discussed the pathophysiology, of course, in terms of the fluid mechanics. Now let's see the pathophysiology of the cardiac remodeling. Why are we discussing the cardiac remodeling here? Because the next step would be to talk about the treatment, and you are going to reverse whatever the pathological mechanisms that have happened here in the pathophysiology. Myocardial dysfunction, it could be of any cause, but Myocardial dysfunction will result in reduced cardiac output, and that will result in the activation of compensatory mechanisms, that are activation of sympathetic system, RAS activation, and then ADH production, right? So start with the sympathetic nervous system. When there is activation of sympathetic nervous system, it acts on alpha 1 and beta 1 receptors. The alpha 1 receptors are going to vasoconstrict the systemic blood vessels, right? Systemic vasoconstriction, and that will result in increase in blood pressure. But when there is an activation of beta 1 receptors, they are going to increase the myocardial contractility as well as its heart rate, positive inotropicity as well as positive dromotropicity, right? So there is increased heart rate and increased cardiac output that is going to reduce. When the heart rate increases so much, it is going to reduce the diastolic filling. What happens when there is reduced diastolic filling time? When the diastolic filling time is significantly reduced, the coronary blood flow is also reduced, because diastole is the usual phase where the coronaries get filled with blood. Now, a pathological effect of excessive activation of beta 1 receptors is calcium overload and myocyte apoptosis, right? Calcium overload and myocyte apoptosis. That will result in the abnormal cardiac remodeling. What will happen when the myocyte apoptosis happens? It is again replaced with collagen, and eventually the fibrosis forms, like you see in any case of the wound healing. Now, when you activate this myocardial dysfunction, a compensator mechanism that gets activated is renin angiotensin aldosterone system, right? So the angiotensin 2 is directly mediating the hypertrophy and the collagen synthesis in the heart, and that is again contributing to the collagen deposition and abnormal cardiac remodeling, right? And on the other hand, angiotensin 2 is also increasing the production of aldosterone, which is contributing to the sodium and water retention in the body. And the third segment, which is increasing the production of ADH, will also increase the reabsorption of water from the collecting tubule. And finally, both of them is going to result in fluid overload. Again, the fluid overload will put the pressure on the heart, and that will result in hypertrophy of the ventricular myocardium. Hope you understood this. Now let's talk about the drugs, and where are they going to act, and how are they going to block at what level of the pathophysiology. So we have the systemic vasoconstriction. Now you can use vasodilators. What vasodilators we know? We have an arterial vasodilator, which is hydralazine, and of course a combined arterial venous dilator, which is isosorbide dinitrate. Okay, nitrates can be used, and there is increased heart rate now. We can use beta blockers or another drug which blocks the funny current sodium channels. The drug is ivabradine. We have beta 1 receptor activation. Block them by using the cardioselective beta blockers, right? And on the right side, as you can see here, we have the angiotensin 2 increase. The drugs that block the angiotensin 2 are the AC inhibitors and ARBs, or ARNI. ARNI stands for angiotensin receptor neprilysin inhibitor, right? Then we have increased aldosterone here. You can block the aldosterone by giving mineralocorticoid receptor antagonist, right? And then we have increased the ADH here. We can block this by using tolvaptan. And we have the fluid overload here, and you can reduce the fluid overload by giving diuretics. What diuretics? Loop diuretics preferably. And after that, you can also add thiazide diuretics like metazoline if you want. And there is a alpha receptor here. The researchers have tried blocking this alpha receptor with alpha blockers as well, but it has not shown any improvement in the management of heart failure, hence we don't use them. Right. So these are all the drugs that you are going to use for blocking different levels in the pathophysiology of the heart failure. Now let's see how are we going to utilize them in the management of our patient. So treatment of heart failure with reduced ejection fraction. So we have put them under the first line drugs and the second line drugs. We call them as the first line drugs because these first line drugs had the mortality benefit in the patients of heart failure with reduced ejection fraction. The first line are M, which are mineralocorticoid receptor blockers or mineralocorticoid receptor antagonists, namely spironolactone and eplerenone. Spironolactone does have a common side effect of gynecomastia, which can be prevented with usage of eplerenone. And beta blockers, we are not going to use. See, all the other drugs in the first line group except beta blockers are going to have a class effect. Class effect means whichever drug you use utilizing a particular class, it is going to have some benefit in the reduction of the mortality in the patients of heart failure. But for beta blockers, it is not going to have a class effect. You need to use specifically cardioselective beta blockers. They are carvedilol, bisoprolol, and metoprolol. Among them as well, carvedilol and bisoprolol are preferred to metoprolol. And next comes the ARNI, angiotensin receptor neprilysin inhibitor. The drug is sacubitril valsartan combination. It is preferred than the angiotensin receptor blockers or angiotensin converting enzyme inhibitors. And finally, SGLT2 inhibitors. The useful drugs here are dapagliflozin and empagliflozin. What are certain second line drugs now? The second line drugs are hydralazine, isosorbide dinitrate combination. They can be used if the first line cannot be used. If the patient is having advanced kidney disease and all, you are afraid that it may progress further by the utilization of the mineralocorticoid receptor antagonists as well as the angiotensin receptor blockers and ACE inhibitors. That is why if you are not able to use those drugs if the patient is having CKD, then you can use hydralazine with isosorbide dinitrate. Digoxin can also be used if you are not able to use the first line drugs, but the proper indication would be if the patient is having heart failure with atrial fibrillation, because it is also going to have some AV nodal blockade. Right? So digoxin can be used. And lastly, ivabradine. Ivabradine has a very specific indication. So when can you use ivabradine? You can only use ivabradine in those patients where the where the heart rate is more than 70 despite using the maximum tolerable dose of beta blocker. Okay, despite using the maximum tolerable dose of beta blocker, if the heart rate is still more than 70, only then you can use the ivabradine. Now, if the patient has congestive symptoms like pulmonary congestion, pulmonary edema, and if the patient comes to in acute heart failure as well, the first drug that should be given are the diuretics. Diuretics, preferably high ceiling diuretics like loop diuretics that are torsemide and furosemide can be given. Along with them, if you want, you can add a thiazide diuretic like metalazone. But metalazone and loop diuretics can be used in acute heart failure to immediately reduce the congestion, whereas the other thiazide diuretics like hydrochlorothiazide and chlorthalidone are preferably used in chronic heart failure, not in acute decompensation. They are not that effective. Now we have the non-pharmacological treatment for this patient. Other than these drugs, we have the implantable cardioverter defibrillator or ICD placement for the patient, right? So the word itself is telling you defibrillator. So it should be used when the patient is having fibrillation. See, because of the cardiac remodeling that is happening, there is collagen deposition, and collagen deposition is going to result in fibrosis. The fibrosis can be a substrate for the development of arrhythmias in the patient. So when the patient develops ventricular fibrillation or ventricular tachycardia, it can be an imminent cause of death. Okay, so it will suddenly result in the death of the patient. So even though the patient is not having fibrillations or ventricular tachycardia previously, if the patient is having an evidence of coronary artery disease and heart failure, you can still advise the patient to undergo ICD placement. Okay, a point to note here. So whether the patient is having arrhythmias or not, it doesn't matter, because of gradual cardiac remodeling that is happening inside the heart, the patient may eventually develop ventricular fibrillation in the future. To prevent that, just place an ICD. Okay, and then we have another modality which is cardiac resynchronization therapy. Again, this is also because of the cardiac remodeling and fibrosis that is happening. See, if an entire myocardium is there, let's suppose this is the entire ventricular myocardium, and this part is fibrosed. So the ventricular impulses, the electrical impulses may not transmit from one side to another side because of this obstruction, that is fibrosis, because of which certain part of the myocardium may not function properly and may not contribute to the efficient pumping. Okay, so we pace the ventricles with two different pacemakers. Okay, it is called as the biventricular pacing. Sometimes we can use a multifocal pacing as well. So we are just pacing the ventricles so as to utilize all the entire myocardium for the effective pumping. Hope you understood this. So, but when should you use this? When the patient is having class 2 or class 3 heart failure, when the ejection fraction is less than 35%, and when the patient is in sinus rhythm and the patient is having left bundle branch block with a QRS duration of more than 150 milliseconds. This can also be used in a patient of heart failure with evidence of coronary artery disease, and even if the patient is in class 1 heart failure as well, if the patient has evidence of coronary artery disease, you can still give the cardiac resynchronization therapy. And lastly, if nothing is working for the patient, what you can do? You can do a cardiac transplant. Understood? So this is all the management of heart failure with reduced ejection fraction. Now, when we talk about the heart failure with preserved ejection fraction, the only drug that has proven to be of mortality benefit, even till the last year, we used to say there is no drug that has been proven to have the mortality benefit. Now we have a drug which is SGLT2 inhibitors among MBAS. Of course, I have not mentioned. So the four first line drugs that are used in the heart failure are M, B, A, and S. Mineralocorticoid receptor blockers, beta blockers, RNI, and S for SGLT2 inhibitors. The SGLT2 inhibitors are the only drugs that have shown to be having some mortality benefit in the management of heart failure with preserved ejection fraction. Okay, but when we are managing the patient, we are not going to give this drug only. We are giving all the drugs anyway. And is there any role of the non-pharmacological management in the heart failure with preserved ejection fraction? Yes, there is. But primarily it is used in the patients of heart failure with reduced ejection fraction. It can also be used with heart failure with preserved ejection fraction. Now, that is about the management of heart failure. I hope you understood the pathophysiology, the clinical features, and management. If you like this video, please share, subscribe. If you want some MCQs on the topic, please refer to my short section. You will have a lot of MCQs there. Thank you. We'll meet you in the next video.